Okay, so this morning we're going to talk about the evolution of radiology with a focus on musculoskeletal MRI. It's rare when you talk about any science, any discipline, any specialty, that you can pinpoint the exact birth of that specialty. But in the case of radiology, that date is November 8th, 1895, because that was the date that Röntgen first produced X-rays. This is the very first radiograph of Röntgen's wife's hand, and this changed the world. It was amazing how quickly this technology took off. It was December 28th, 1895, when Röntgen presented his work, A New Kind of Ray, and this really spread like wildfire across the world. As a matter of fact, it was less than 2 months after that Sir Robert Jones, my hero, published the first article using X-rays to discover a bullet lost in the wrist. Röntgen was given the very first Nobel Prize in Physics in 1901 for his discovery of X-rays. And we still use X-rays today as a diagnostic tool because there's lots of things that we can see with X-rays, although there's lots of things we can't see with X-rays. For example, X-rays are very good at seeing the bones. So we can look at things like fractures, but we can't see very well is inside the skull. You cannot see the brain using regular X-rays. And what we're going to see is really the whole evolution of radiology has been trying to see the brain. Now, certainly we can see the joints, we can see joint width, we can see the articular surfaces, we can talk about arthritis, we can look at things like osteophytes and erosions, but you really can't see inside the joints with X-rays. You can't see tears of ligaments and tendons, of menisci and cartilage, all the things that you guys are really interested in. You can't see any of those things with X-rays. One of the big things we have to keep in mind is that the radiographs, the pictures generated by the X-rays, represent a two-dimensional projection of a three-dimensional patient. What this means is radiographs flatten everything. Whenever you're dealing with radiographs, you can't tell what's in front and what's behind if you only have one view. And that's why whenever we're dealing with radiographs, you need to have multiple views. We have an expression in my department, one view equals no views. I'm going to highlight this. I'm going to put some blinking lights on this. This is my first take-home message from this lecture. You need to have multiple views with radiographs. Let me show you an example. This is a made-up example, but here I am stabbing a steak knife through my skull. Not really, but if you only have one view, you can't see what's in front and what's behind. Here's the side view, and you can see I'm just holding up the steak knife in front of my skull. But you have to put the two views together in your own brain to tell what's in front and what's behind. You need to have multiple views. Now that's a made-up example, but here's a real example. Here's a nice view of the small finger, well-positioned, well-exposed. You can stare at this all day and not see anything wrong with it. This is the PA view, this is the oblique view, and this is the lateral view. That's not a very subtle fracture, but the fracture fragments overlap each other so perfectly on the PA view that they're undetectable. You need to have multiple views, at least two orthogonal views whenever you're dealing with radiographs. And frankly, when you're dealing with joints, you need to have three views. And later on, when I discuss the different joints, I will teach you all the different views you need to get. But here's a very common example. Patient comes into the emergency room and they're complaining about something going on at their index finger PIP joint. Well, it looks pretty good on that PA view. Here's the oblique view. Maybe it's a little bit subluxated. Here's the lateral view. This finger is frankly dislocated. It's hard to even imagine how this view corresponds to the other views, but we see this all the time. You need to have multiple views. So one of the big leaps in the evolution of radiology was the development of CT. CT stands for computed tomography. Tomography comes from the Greek tomo, meaning part or slice. So anytime you hear the word tomography, it means that we're imaging the patient slice by slice. We also call this technology CAT scanning for computed axial tomography because we typically scan the patient in the axial plane top to bottom. CT was actually conceived of back in 1917 by an Austrian mathematician named Radon, who proved that an image of a three-dimensional object could be reconstructed from an infinite number of two-dimensional projection images of that object. He also proved that the equations were too difficult to be solved, so nothing happened with this until the 1970s, when they started developing these large mainframe computers and were able to crank through Radon's equations. But the real hero in the development of CT is Godfrey Hounsfield. In 1972, Godfrey Hounsfield, a British electrical engineer working at the EMI laboratories in London, developed the very first EMI brain scanner. And this is it, the EMI brain scanner. In many respects, it's just like a modern CT scanner. It was small, only your head fits in it, but remember, before 1972, you couldn't see the brain at all. This was a revolution. Finally, we could see through the skull into the brain. Hounsfield was awarded the Nobel Prize in Medicine in 1979. He was knighted in 1981. And to this day, when we, in the CT reading room, when we look at the CT scans, we use the term Hounsfield units, is the scale that we use to measure CT density. But personally, I think the most interesting part of this whole story is the role of EMI. Does anybody know what EMI is? EMI stands for Electric and Musical Industries. EMI was the Beatles record label. The Beatles funded CT research. And here on the cover of this Please Please Me album, the Beatles are standing in the stairwell of the EMI building. So why is CT so great? Because we can see the brain. We can see strokes, we can see bleeds, we can see tumors, but we don't only nowadays scan the brain, we scan everything. We can see the organs, the lungs, the liver, the bowel. So we can see tumors or trauma, acute and chronic disease, and we can see fractures that would otherwise be missed. Now, almost all fractures we work up with radiographs because they're the best way of seeing things. They're quick, they're cheap, there's low radiation, but there's certain places where fractures can be hard to see. One's in the cervical spine and one's in the pelvis. And when patients come in with trauma to the emergency room, we usually get CTs of those body parts. And now with our ultra-fast multi-slice CTs, we can even scan the heart in a single heartbeat. This is amazing what we can do now, that we can see the coronary arteries, we can see pulmonary emboli, we can do this all with basically a single heartbeat, a single breath hold. And that's why all modern hospitals have CT scanners right in their emergency rooms to really help with doing this type of very urgent imaging as quickly as possible. Here's just an example of how CT use has increased in the emergency rooms over the years. Back in 1998, when I kind of started doing this stuff, if a child came into the emergency room with abdominal pain, less than 1% of those kids would get a CT scan. And you could see as we moved into the 2000s, those numbers increased. And by 2006, 2007, 16% of kids coming into the emergency room with belly pain were getting CT scans. In a sense, that's a good thing. We can diagnose things very quickly, like appendicitis or other causes, but we have to keep in mind that the biggest problem with CT is that it's a high radiation dose. Now, I don't want to be overly paranoid about radiation. We are exposed to low levels of radiation every day just living on the planet Earth. That's called background radiation. This background radiation comes from three sources. The Earth itself has naturally occurring radionucleotides, like uranium-238, potassium-40. Right now, there's radioactive potassium inside your bodies. The atmosphere itself contains radon-222, a byproduct of uranium-238, and I was surprised to learn that radon-222 is the second leading cause of lung cancer after smoking. And the third source of radiation is from space, from cosmic rays. Things like solar flares and space itself spits out cosmic rays, which are radioactive. Now, very few of those actually reach the surface. The upper atmosphere blocks most of those cosmic rays. But people like airline crews who spend a lot of their time in the upper atmosphere, they receive twice the typical background dose than those of us who stay on the ground. but it's been estimated that the average background dose just living on the planet Earth is 2.4 millisieverts per year. 2.4 millisieverts per year. That number means nothing to me. I don't know what a millisievert is. So let's compare this to something I do understand, like a chest x-ray. A chest radiograph is 0.6 millisieverts, basically like 1 week's of background radiation. What I'm saying is a chest radiograph is like nothing. It's just like living on the planet for a week. That's as much radiation as you get from a chest x-ray, essentially nothing. So we don't worry about chest x-rays. We get them all the time on people. But if you look instead like a chest CT is more like 7 millisieverts. Now we're talking about 3 years worth of background radiation. But maybe the question we need to be asking is how much radiation is too much? And I've been asking this question to my physicists for years. And I don't know if you've ever tried asking a question to a physicist. They don't give you a straight answer. But finally, in 2011, the American Association for Physics and Medicine came out with this statement, that the risks of medical imaging at effective doses below 50 millisieverts for single procedures or 100 millisieverts for multiple procedures over short time periods are too low to be detectable and may be non-existent. So what this means is that even a chest CT at 7 millisieverts, 3 years worth of background radiation, is considered to be negligible. So we try not to overuse CT, but if CT is needed to make a decision right away to help manage the patient, are we admitting them or sending them home? Are we taking them to the operating room or not? Are we giving them medication A or medication B? We are happy to do these CT scans if it helps make the decisions. What I want to try to avoid is serial CT scans close together. If a patient comes in with pneumonia, we're going to work that up with a chest x-ray, maybe serial chest x-rays. But we're not going to work that up with serial chest CTs, as gorgeous as they are, because now we're talking about appreciable radiation. Other problems with CT is it usually requires that we give intravenous contrast. That's not a big deal, but about 1% of people are allergic to CT contrast, and it can affect renal function. Certainly, CT costs a lot more than radiographs. I've tried to get some of the charges here at the UW. They're not very forthcoming on how much they charge for things. But as far as I can tell, if you want to image your patient's knee, they've injured their knee, you get their standard 4-view radiographic series. That costs all of $154. In the world of medicine, that's a bargain. Because if we compare that to a knee CT, now we're talking about $1,200. And it doesn't really show me that much, because I can't see structures inside the joints. In the knee with CT, I can't see menisci, I can't see ligaments, I can't see cartilage. In the shoulder, I can't use CT to see the rotator cuff, the labrum. In the spine, I can't use CT to see discs, to see the spinal cord. So CT is very good for some things, but not for others. That's where MRI comes into play. In the evolution of radiology, if CT was the giant leap forward, I consider MRI to be a giant leap sideways. Because MRI is unlike everything else we do in radiology. MRI doesn't rely on X-rays to see projected shadows of patients. So it's unlike radiographs or tomography or CT. MRI sees tissues based upon their subatomic characteristics. We're actually looking at the proton nucleus of the hydrogen atom. We used to call this NMR for nuclear magnetic resonance, but people didn't like this term because nuclear sounds radioactive, and there is no radiation associated with MRI. People also used to joke that NMR stood for no more radiologists, because the pictures were so beautiful you can see everything. And that's true, but it turns out just the opposite is true. Because the pictures are so detailed, you actually now need specially trained radiologists to interpret all the details on these very high-resolution MR scans. But nowadays, we just call this technology MRI for magnetic resonance imaging. So now I'm going to tell you about the MR scanner. The MR scanner consists of two components, the magnet and the coil. Now, the magnet is a magnet. In many respects, it's just like a horseshoe magnet you may have played with in junior high school. And if you take a compass and you slide it next to that magnet, what's going to happen? The compass is going to point north-south. And that's going to happen whether you have a horseshoe magnet or you have an electromagnet. And an electromagnet is nothing more than a coil of wire that we pass current through. Well, that's what my MR scanner is. It's a very big coil of wire, and I'm passing a lot of current through it. And instead of putting a compass in there, I'm putting a patient in there. But if you will, your patient consists of a whole lot of little compasses. These are these proton nuclei that are normally randomly spinning around just randomly in your body. So if I take your patient and I put them inside my magnet, what's going to happen? All these little compasses are going to line up pointing north-south. Not really, but for illustration purposes, this is good enough. My point being is if I only had a magnet, I would now only have a magnetized patient. I can't actually take pictures at this point. To take pictures, I need to have the coil. Now the coil is another coil of wire that we wrap around the body part of interest. Here I'm simulating a head coil. The coil has two jobs. Its first job is to act like a radio frequency transmitter, like a TV tower. It takes radio frequency waves and it sends them inside the patient. And then at that point, the coil turns off. It takes the radio frequency waves, sends them into the patient, and those radio frequency waves are tuned to take all your little compasses that are pointing north-south and knock them over, so they're now pointing east-west. And at this point, the coil turns off. It stops acting like your radio frequency transmitter, and instead, it starts acting like a radio frequency receiver, like a satellite dish. Because now that all your little compasses are not being bombarded by external radio frequency waves, knocking them over, they're all going to want to spin back north. And as they spin back north, they give off little tiny radio frequency waves. My coil is sensitive enough to hear those radio frequency waves, map them in 3 dimensions. That's how we make an MRI scan. So the way the MR scanner works is the magnet is there to align the spins of the protons in the hydrogen nuclei, and it aligns them in the direction of the magnetic field, and we call that direction B0. The coil does everything else. It first takes a radio frequency pulse and it flips the spinning protons, and after the RF pulse is turned off, the protons realign to B0. And as the protons realign, they resonate radio frequency energy. The coil then measures the strength of that radio frequency echo, but we measure it at a specific time, the TE, the echo time. There's going to be a lot of T abbreviations coming at you. Try not to confuse them. The echo time is the time we listen to that resonant frequency, the TE. We then repeat steps 1 and 2 many, many times for each imaging slice, and we repeat that knocking over the echoes at a repetition time of TR. The 2 things that we control are the TR, the repetition time, and the TE, the echo time. And the key to MRI is to realize that specific tissue types have specific resonant echoes. We call those echoes T1 and T2, depending upon how we specify, how we program in the TR and the TE. I know that's confusing. I'm going to sort it out for you now. Basically, we're going to look at 3 different types of tissue. We're going to look at fluid, really the hydrogen protons in the water molecule. All fluid looks the same to the MR scanner, be it fluid in a simple cyst, be it fluid in a joint effusion, be it fluid in the soft tissues of the bone marrow, which we call edema. All of that looks the same to MRI. We're also going to look at fat, the protons, the hydrogen protons in fat molecules, be it fat of your subcutaneous fat, or the fatty yellow bone marrow inside your bones. All fat looks the same to MRI. And the third thing we're going to look at is the dense stuff, the stuff with very few hydrogen protons, the things that I, as a musculoskeletal radiologist, am interested in, like the cortical bone, ligaments and tendons, menisci. Dense stuff has its own signal characteristics. I'm now going to draw a couple of graphs. Don't panic. I don't think you have to memorize these graphs, but but I think it really helps you to visualize where all this stuff is coming from. The first graph is called a T1 recovery curve. On the x-axis, I'm going to plot time, just like any normal graph. And this is that time to echo, that TE in milliseconds. Now on the y-axis, this is kind of a funny axis. It's just called signal. It doesn't really have any units. It just goes from low signal to high signal. Now for a T1 weighted image, that TR, that I'm knocking down the pulses, that TR is short, about 500 milliseconds, about half a second. Every half a second, we're sending in a pulse, and then we're listening to it come back. And we're going to look at the three characteristic tissues, fat, fluid, and dense stuff. Fat has a recovery curve that looks like this, fluid like this, dense stuff like this. So what this graph is telling me is at a very short time to echo, I can listen as early as 10 milliseconds, and I get very good separation of fat from fluid and from the dense stuff. We call this a T1 weighted image. In a T1 weighted image, the TR is short, usually around 500 milliseconds, and the TE is short, around 10 milliseconds. When I use those parameters, the fat, the normal fat tissue, is going to have the highest signal. The fluid is going to have low signal, and the dense stuff is going to have low signal. So T1 is really good at seeing fat. Compare this to a T2 decay curve. On a T2 decay curve, that TR is much longer, more than 2,000 milliseconds, more than 2 seconds. So every 2 seconds or more, I'm knocking those pulses down. The T2 decay curve looks like this. Fluid decays like this, fat like this, and dense stuff like this. So what this is telling me is to get separation of fluid from fat, you have to listen way out here at around 80 milliseconds. This is how we make a T2 weighted image. T2 weighted image have a long TR and a long TE. And in a T2 weighted image, the fluid is going to be intermediate in signal intensity, although it's still going to have higher signal than everything else. The fat is also intermediate in signal intensity, but the dense stuff has very low signal. But we can do better than this, because what we can do to increase the separation of fluid from fat is we can apply what's called fat suppression or fat saturation. And that takes the signal from fat and it knocks it down. So the fat is now low because it's suppressed, and we get very good separation of fluid from fat. And almost all the scans that we do here at the UW, the T2 weighted images are fat suppressed because T2 is best for seeing fluid, and we're trying to see the fluid best by suppressing the fat. Matter of fact, my residents think that fat is normally dark on T2 weighted images because every image they've ever seen is fat suppressed. I'm going to mention that I think it's always preferable to suppress the fat on a T2 weighted image to increase the fluid conspicuity. Sometimes we'll do something called inversion recovery, IR or STIR, it's the same thing. So if you hear the term STIR or inversion recovery, or you see that on an image, just think fat suppressed T2. And I'm going to show you some images in a minute. One more thing we can do, I told you this scale is really unitless, it's kind of an arbitrary scale. Since on these T2 weighted images, we're only working on this low part of the scale, we can compress the scale downward. And by compressing the scale downward, now we're just mapping that fluid to this high part of the scale. It's still only intermediate in signal, but by mapping it to the upper part of the scale, it's now relatively high compared to everything else. And this is how we make their MR images. The magnetic field divides the body into slices, and then each slice is further subdivided into voxels. What's a voxel? A voxel is just a three-dimensional pixel. The voxel size is your two-dimensional pixel size times the slice thickness. And our coil basically measures the signal in each voxel, and the computer maps it onto two-dimensional slices. If it has high signal, it maps as a white pixel, and we'll call that bright. If it's intermediate signal, it's going to map it as a gray signal. We call that iso-intense. And if it's low signal, it's going to map it as a black pixel. We call that dark. Okay, let's look at some images. I'm now going to look at some images right through the very middle of the knee, same exact slice position, but different sequences. This is a T1 weighted image right through the middle of your knee, a sagittal slice like this. We know it's T1 because the TR is short, 400 milliseconds, and the TE is short, 10 milliseconds, but we didn't even need that information because we just look and we see what's the brightest thing on the image. It's the fat. This is a T2 weighted image. Has a much longer TR, a TR of 2500 and a TE of 80. And this is a similar T2 weighted image, but now we've suppressed the fat. Same exact position, but now you can see how the tissues change. Notice on the T1 weighted image, the fat is bright, be it the subcutaneous fat, or the fatty yellow bone marrow, or the fat in Hoffa's fat pad. Fat is bright on a T1 weighted image. On a T2 weighted image, notice the fat is more intermediate in signal intensity, and on a fat suppressed T2 weighted image, the fat is dark because we're purposely suppressing the fat. But what I really want to show you is the fluid. This patient has a cyst in front of their knee, this round fluid-filled cyst, but you can't even tell it's a cyst on a T1 weighted image because T1 doesn't really show fluid. T2 shows fluid as high signal, so you can see that nice round cyst sitting in front of the knee, and it's even more conspicuous on the fat-suppressed image because only thing that's bright on a fat-suppressed T2 weighted image is fluid, is the cyst. One more thing about this T2 decay curve, I told you that we usually wait about 80 milliseconds to get separation from fat from fluid. But for computers, 80 milliseconds is like an eternity. So while we're waiting that 80 milliseconds, we like to listen over here at around 20 milliseconds. We kind of do this for free. Now at 20 milliseconds, we get very poor separation of fat from fluid, but we get great separation of the dense stuff from the fat and fluid. And we call this a proton density weighted scan. Proton density is kind of halfway between a T1 and a T2. It still has a long TR like a T2 weighted image, but it's got a short TE like a T1 weighted image. Now, we don't use proton density to tell fat from fluid. They look almost exactly the same. But it's very good for seeing the dense stuff because we got good separation of the dense stuff from fat and fluid. Let me show you what I'm talking about. So here's that same T1 weighted image I've already showed you. Here's that same fat suppressed T2 weighted image I've already showed you. And in between them, I'm going to put the proton density weighted image. This has a long TR of 2500, but a short TE of 20 milliseconds. Notice the cyst, the fluid, which is low on T1 and high on T2, is intermediate in signal intensity on proton density. Notice the fat that's high on T1 and suppressed on the T2 is also intermediate in signal intensity. But the real value of the proton density is to look at the dense stuff. For example, the menisci. The menisci are those two black triangles right there. Notice how well you can see the black triangles of the menisci separated from everything else in the proton density weighted image, as opposed to how hard it is to see the menisci on the T1 or T2 weighted image. And this is why in MRI, we need to have multiple sequences. We like the T1 weighted image because T1 shows fat best. And since most normal anatomy is surrounded by fat, in essence, T1 shows normal anatomy best. The T2 shows fluid best, but most pathology, infections, trauma, tumors, they contain fluid, they show edema. So in essence, T2 shows pathology best. And we like to apply fat suppression because it makes the fluid even more conspicuous. Proton density shows the dense stuff best. It's very good for meniscal tears, tendon tears. It's used primarily for musculoskeletal radiologists doing MRI of joints. It doesn't tend to be used in the brain or the body. It's something that we use for looking at meniscal and tendon tears. Now, MRI is great. It's about half of what I do. It's really been a revolution to radiology, but there are several limitations of MRI that you should be aware of. One that's important for you to understand is this idea of limited field of view. The image resolution is related to that voxel size. The smaller the field of view, the smaller the voxels. The smaller the voxels, the higher the resolution. So to maximize resolution, we always try to limit the field of view. But the reality is we can only image what's inside the coil. And this requires that we have an assortment of different coils for different body parts. Let me just show you some coils. This is an example of a knee coil. This is the highest resolution coil they make because we need very high resolution images to see these sub-millimeter meniscal tears that you're worried about. So I love using the knee coil, not only on the knee, but I can move it to other body parts. Like the knee coil works great for the ankle, but notice the toes are sticking up to the top of the coil. So I can't actually use this coil to image the toes. But that's okay, we have a dedicated foot coil where the toes fit up inside that chimney there. We got lots of coils. We got a dedicated coil to wrap around the elbow. We got a dedicated coil to wrap around the wrist. Oh, this is what happens if you bring your digital camera too close to the magnet. It messes up your pictures. This is a two-part torsal coil, and we use this to sandwich the hips of this athlete between the top and bottom parts of the coil. Notice that the coil doesn't even cover the entire length of the thigh. Limited field of view, limited by the size of the coil. So we have many coils that are needed. All of our MR scanners have these shelves with all these coils stacked up because depending upon what body part you need us to scan, we got to put that coil on the table. The biggest problem with MRI is these scans are very expensive. Why are they so expensive? Well, first of all, these coils are expensive. These coils cost like $25,000 a piece, and you need to have a bunch of coils for each of your scanners. The scanners themselves are expensive. They start at $2 million and go up from there, and I guarantee here at the UW, we don't buy the cheap scanners. You need specially trained technologists. They're expensive. But the big issue is MRIs take a long time. They take 30 to 60 minutes because I have to run several sequences, T1, T2, proton density, in several planes, axial, coronal, sagittal. That means I can only scan a limited number of patients per day, so we have to charge a lot per each scan to pay for all this equipment. Just regarding charges, we already said a knee radiograph costs about $154, whereas a knee CT costs $1,200, and you can't see anything inside the joint, so we don't do a lot of knee CTs. We do a lot of knee MRIs, but now you're talking about $2,400 of cost. Now, in these days of managed care and HMOs, nobody actually pays that much for a scan. I think we're lucky if we can collect 30 cents on a dollar. And I don't get paid that much to read them. I get paid like $1.50 to read them. But my main point is, for you guys, when you're working up patients with pain, we never want to start with the MRI. You don't want to get a musculoskeletal MR before getting the radiographs, because the answer may be there on the radiograph. You may see an obvious fracture. You may see obvious arthritis. Only if the radiographs don't answer the question, though you or the physician assistant or the doctor maybe think about getting an MRI. Don't get MRIs if you haven't gotten the radiographs first. Now, if you're going to talk to your patients about MRI, warn them that these are long scans. These scans take 30 to 60 minutes, and the patient needs to lay still like a statue for the entire length of that scan. If the patient is ill the day of the scan and can't stop sneezing or coughing, they should reschedule. I can't be scanning people who are wiggling around. If you have a patient who can't lie flat, like they've got such severe heart failure that they can't lie flat on their back, they can't get an MRI. We don't have an upright MR scanner. So let me just show you what these scanners look like. I don't know if you've ever seen a CT scanner. This is what a CT scanner looks like. A CT scanner is kind of like a donut. So if a CT scanner is a donut, an MR scanner is a cannoli. Basically, the MR scanner is a tube. Now, we don't build these tubes to torture your patients. This tubular design is needed to achieve the high magnetic field inherent to MRI. This is a 1.5 Tesla magnet. Tesla is a measure of magnetic field strength. The Earth's magnetic field is 30 microtesla. Your typical kitchen refrigerator magnet is 3 millitesla. My high field MR scanners are between 1.5 and 3 Tesla. That means my scanners are 1,000 times the strength of your kitchen refrigerator magnet and 100,000 times the strength of the Earth's magnetic field. These are very big magnets. Now, I am going to mention there are such things as open magnets, but these are low field magnets. These are favored by the commercial standalone MR sites. They like to run ads like this. Our MR scanner is open on all 4 sides. That's a major advantage for large people who find a tunnel too confining, for children who might become frightened inside a tunnel, for anyone with a touch of claustrophobia. I'm getting claustrophobic just reading this. And they like to put these big ads and they love showing these pictures like this. They always show this picture of a kid laying in the scanner with their mom sitting next to them reading a story. Here's another one where the kid's there and the mom's holding their hand, reading a book to them. Here's one they painted to make look like fishies, anything to make the kids feel more comfortable. And they'll even run these big billboards on the belt line saying, oh, you can just lay there and comfortably read a magazine. Here's another guy, I don't know if he's reading the same magazine. The problem with these open magnets is that they're low field magnets. They're 0.1 to 0.3 Tesla. That means they're 1/10 the strength of our high field scanners. These are 1/10 the image resolution of a high field scanner. Now, they certainly cost 1/10 the price to buy a low field scanner as opposed to a high field scanner. That's why the commercial sites like them. But the thing is, they charge the same amount as a high field scanner. There are not 2 different charges for MRI. They don't have a discounted charge for a low field versus high field. They just charge for MR. I'm willing to go on record as saying that the diagnostic value of low field MR is inferior to that of high field MR. And we have some experience with this. This is a magnet we used to have here at the UW. This was the only open magnet we've ever had. It's a 0.7 midfield Tesla. It's not even a low field. This is the highest field strength open scanner made. We here at the UW, we're considered the world experts on knee MRI. We've written all the papers on knee MRI. In a 1.5 Tesla scanner, our accuracy on knee MRI is like 95%. In this scanner, our accuracy dropped to 75%. Same UW radiologist, same protocols. It wasn't us. It's the low field scanner. The diagnostic value of low field is inferior to that of high field MR, and we have no low field open magnets in the UW system at all. It got so bad that our surgeons even refused to schedule patients in the open scanner. We ran it only 2 days a week, and we used it primarily for the obese patients, the patients who just didn't fit inside the 1.5 Tesla scanner. And as bad as the scanner was, it did a particularly poor job with the obese patients. I mean, you can just imagine this guy is laying on my scanner, laying on my spine coil. There's like a foot of fat between his spine and the coil, killing all my signal. There is no good way to image obese patients. We eventually got rid of this open scanner and we replaced it with a 3 Tesla scanner, and we love the 3 Tesla scanners. My recommendations to you or to your patients or to your family is don't use open low field scanners. You always want to use at least a 1.5 Tesla scanner. And frankly, if it was me, I'd want to get a 3T scanner. I mean, it's like going from regular TV to HD TV. It's really, at least to my eye, a dramatic change. But what about the obese patients? What about patients who don't fit inside the 1.5 Tesla scanner? Well, we have an alternative to low field open scanners for the Wisconsin-sized patient. And that's our wide bore scanner. And we're starting to get more and more of these wide bore scanners out there. It's still a tube, but it's a much wider tube. It's actually the same size opening as a CT scanner. And this table can hold up to 500 pounds. If your patient weighs more than 500 pounds, they ain't fitting in any of my scanners. One nice thing about this wide bore scanner, it's also a very short bore scanner. So wide bore plus short bore means less of that closed in feeling. And yes, the MR scanner is a tube. And yes, being inside this tube does cause some claustrophobic feelings in some patients. So let's talk about that right now. The biggest thing I can tell you guys is don't make your patients claustrophobic. And let me tell you what I mean by that. Here at the UW, we pride ourselves on MRI. We actually customize the protocols for each and every one of your patients. So I read the clinic notes, the chart notes. It's very interesting, some of the things I've seen clinicians write. I've seen them write, I told my patient how traumatic an MR scanner is. I told my patient it's like laying inside a coffin. I told my patient it's like laying inside a sewer pipe. That's the wrong attitude, folks. If you tell this to your patients, they're all going to be claustrophobic when they come to me. I'm going to make you guys the same offer I make to all the medical students. If at some point you want to wander over to the hospital and find your way to the MR suite, you can tell the MR technologists, Schreibman says I need to lay in the MR scanner. And I think if you were just to lay in the scanner just for 5 minutes, it'd be a very useful exercise. Now, I'm not going to yank a patient out just to put you in the scanner, but I think if you were to lay there just for 5 minutes, you'll see what it feels like. And then the next time you're talking to somebody about needing an MRI, you can look them in the eye and say, hey, I've been in there myself, it ain't that bad, and that will go a long way to dispelling everybody's claustrophobic feelings. Tell them the MR scanner is just a tube, and nothing happens inside that tube. Nothing moves, nothing crushes them, it's open at both ends, plenty of air, no radiation, no x-rays, no flashing lights. If this thing didn't make any noise, you wouldn't know anything's happening. It does make a lot of noise. It makes a very loud knocking or hammering sound. And we always do something to protect the patient's ears. Either we give them earplugs, or most of our scanners actually have headphones, and we can play a radio station or a CD or plug in their iPod, whatever makes the patient more comfortable, more relaxed. That's our goal, is to make the patient relaxed. Now, if the patient wants to take a nap inside the scanner, that's fine with me. I get my best pictures on people who are sleeping. Now, if your patient really is anxious, they can take something mild on an outpatient basis, that's fine. The doctor can prescribe a little Valium to them. Frankly, I'd rather they give them Ativan because it's much shorter acting. If the patient wants to have a cocktail before coming in, I'm okay with that too. I'd rather they don't take all 3 of these. And if they take any of these, they need not to drive. They need to have somebody drive them up there. And if the patient is really problematic, we can provide conscious sedation for them. But that has to be done at the hospital. We don't provide that at our outpatient facilities. If the patient is really, really problematic, general anesthesia can be arranged, but it rarely comes to that. The bottom line is, don't make people claustrophobic. We'll deal with it if they are. But what's the big problem with MRI? It's a big magnet. It's a very big magnet. This didn't happen here. This happened to a colleague of mine, but this magnet literally sucked this wheelchair off the ground. It's a big magnet, and it's always on. Why is it always on? Is an electromagnet, can't I just flick a switch and turn it off? It's not that simple. Yes, it's an electromagnet. Yes, it works by passing current through wire. But to achieve 1.5 Tesla, we need to pass a lot of current through wire. So we have to use low resistance wire, superconducting wire. And superconducting materials, by their very nature, operate at cryogenic temperatures. So all of our MR scanners inherently have some cryogenic material associated with them. Now, that's nowhere near your patient. It's in a separate room. It's pumped in under the floor, but there's no way to turn off the magnet without venting all the cryogens. Occasionally, we have to replenish the cryogens. We bring in the special technologist. He wears these heavy insulated gloves. We get venting of cryogen. Things freeze instantly. It's really very dramatic. I now want to focus on MR safety. And this is very important. Everyone in the entire medical center needs to respect MR safety. You can't bring anything into the scanning room that is ferromagnetic or electronic that is not certified MR compatible. All of this type of stuff that's in every room in our hospital, none of this stuff can go in the scanner. Oh, here's a little video that I stole off the internet. No, you can't bring that floor buffer in there. This guy brings this floor buffer in there, gets too close to the magnet. The magnet grabs a hold of this floor buffer, sucks it across the room, it goes flying into the scanner. Now that's a silly little animated video, but here's an actual floor buffer that got stuck inside a magnet. There's all kinds of pictures like this on the internet. Here's a gas tank that went flying across the room, got stuck in the magnet. Keep this picture in mind in about 5 minutes. Here's an entire ICU bed that got sucked off the ground. This is a very strong magnet. I don't care how much the thing weighs. I don't care how much you hold on to it. This is a big magnet. Like, take this. This is a little desk chair. This desk chair weighs all of 5 pounds. And look how much trouble these guys had getting this thing out of here. There's some guys off camera pulling on this thing with leather straps. This guy is trying to lever this thing out with a 2x4. And at this point, right now, the chair's not even in the magnet, but the magnet is still pulling on the chair. So they have to get the chair this far away from the magnet to finally get it away from that magnetic pull. Big magnet. This happened to me when I was at the University of Mississippi. This is an anesthesia drug cart. This drug cart weighs 200 pounds and it got sucked off the ground. This is like sucking me off the ground. Fortunately, there was no patient inside the scanner when this happened. Unfortunately, we couldn't get this thing out of there. We tried. We got 6 big burly guys and a bunch of ropes to yank on this thing. Not a chance. 1.5 Tesla. 100,000 times the Earth's magnetic field. We had to turn off the magnet. It took us 2 days to ramp down the magnet, 1 day to fix everything that was broken inside here, 2 days to ramp up the magnet, so we lost 5 days of scanning time, and fortunately there was no patient inside the scanner when this happened. We do everything we can to avoid this. We got signs up all over the place, warning, strong magnetic field. For some reason, half the signs are in German. I'm not sure why that is. Oh, this sign I used to laugh at, danger, strong magnetic field. Metal objects may become airborne. But this is not a laughing matter. Think about that ICU bed. Think about that gas cylinder that went flying across the room. Here's a sign that I saw when I was lecturing in China. I kind of like this sign. And in China, they had something I'd never seen before. Here's my team, and we're standing in front of a poster advertising our lecture. But right behind us is a metal detector, just like at the airport. And in China, you can't walk into the MR scanner without going through a metal detector first. Now, we don't do that in this country, but we have many ways of limiting access to our MR suite. You can't walk to the door of this MR control room without a specially coded ID badge. That's only one of several ways we control access in and out of the scanner. We even have this welcome mat, danger, the magnet is always on. Because what we really want to avoid is this. This was a true tragedy, and this never should have happened. This was back in 2001. A little 6-year-old boy by the name of Michael Colombini had undergone brain tumor surgery, and they wanted a post-operative MRI to see if there's any tumor left. Well, we would have done the same thing here. Little 6-year-old boy, you want to give them conscious sedation. We would have also given conscious sedation. And when you give conscious sedation, you like to give the patient some oxygen so they breathe better. Well, here at the UW, all of our MR scanners, we have oxygen built right into the room. So we just run a tube over from the wall and give it to the patient. This particular MR scan center in Westchester, New York, did not have wall-mounted oxygen, but they did have special plastic oxygen tanks just for this purpose. So they're scanning the patient, they're monitoring the patient, the respiratory therapist is monitoring the patient, the respiratory therapist sees that the oxygen tank is almost empty, the respiratory therapist calls for a new oxygen tank, and someone walks into the room carrying an iron oxygen tank. This thing takes off like a missile, smashing this poor little boy's skull, killing him instantly. There was no excuse to have this happen. And this is why I try to give this lecture to everybody in the entire medical center, because everyone in the entire medical center needs to respect MR safety. You can't bring anything into the scanning room that is ferromagnetic or electronic that is not certified MR compatible. The last thing I want to talk about is things inside your patients. And I'm going to make it very simple for you. No implanted electronics. None of that stuff can go into the scanner. Specifically, I'm talking about pacemakers. Now, I'm not saying my magnet's so strong it's going to suck that pacemaker out of the patient's chest, but the magnet may drain the battery, make the pacemaker fire erratically, scramble the electronics. I don't know. I'm not going to find out. As far as I'm concerned, nobody with a pacemaker should go inside the MR scanner. By the way, does anybody know how a cardiologist reprograms a pacemaker once it's inside the patient? They actually use a magnet. They reprogram with a magnet. So my magnet may even reprogram the pacemaker. As far as I'm concerned, and the message I want you to hear from me right now is no pacemakers are going in the magnet, end of story. Except it's not the end of the story, because there are now MR compatible pacemakers that are out there. So we are begrudgingly scanning people with these MR compatible pacemakers, but that's rare. The message I want you to hear from me is no implanted electronics, no pacemakers, no cochlea implants, no neural stimulators. None of that stuff goes in the MR scanner. But what about metal inside the patient? Regarding metal, we can talk about safety issues and we can talk about imaging issues. Metal that can't move is not a safety issue. I don't care about the fillings in your teeth. My magnet's strong, but it's not that strong. It's not going to suck the fillings out of your teeth. I don't care about orthopedic hardware. Anything the surgeon puts in, anything that's nailed down, screwed in, cemented down, scarred down, been there forever, not going anywhere, I don't worry about. What I do worry about is any metal that can move, specifically any metal in or around the eyes. It's surprising how many people have metal in or around their eyes. People who work with welding equipment, people who work with grinding equipment, people who fire guns without proper eye protection, people who have been shot. See, you folks here in Madison, you don't get to see any gunshot wounds. I did my training in Chicago. In Chicago, like everybody's got a bullet in them there. It's like a badge of honor in Chicago. Most bullets are fine. They're embedded in the soft tissues. They're scarred down. They're not going anywhere. But you can imagine a patient could have a little piece of metallic shrapnel in their globe or in their orbit. Could have been there 20 years, not bothering them. They go inside my magnet. My magnet grabs hold of that piece of metal, sucks it through their eyeball. That's a bad outcome. We're not going to have that happen. So if there's any question at all about any metal in or around the eye, that patient has to get radiographs of their skull to see if there is metal there. And if I find metal, that patient does not go to the MR scanner, they go to the ophthalmologist to have that metal removed. The other thing we worry about is old aneurysm clips that are used to clip off aneurysms in the brain that were bleeding. Modern aneurysm clips are not ferromagnetic. But you got some 30-year-old Eastern European clip, I don't know if that's ferromagnetic or not. And you can imagine if this was a ferromagnetic aneurysm clip, it wouldn't take too much torque on it to actually occlude the blood vessels, maybe even tear open the aneurysms trying to be occluded. So we actually require that anybody who has an aneurysm clip, we actually look up what the exact model is and if it's compatible. We have these screening sheets. And we ask them all kinds of questions. Can you have any metal inside your body? And we can look them up in these guidebooks. So let me just show you one actual case. We're screening this patient to see if he's MR compatible. And we asked this patient, do you have any metal in your body? And this patient literally said, yeah, I think I was shot in the head once. I would have thought if he was shot in the head, that'd be a memorable experience. But maybe because he was shot in the head, he didn't remember. So my question for you guys is this patient MR compatible? Yes or no? Well, maybe yes, maybe no. Let's get a skull radiograph. So what do you say now? Well, I think what you're supposed to say is one view equals no views. This is, again, we need to have multiple views. This is an example of the Waters view. It's kind of an upward-looking view. It's a nice view for showing the sinuses, and here's that bullet projecting right next to his orbit. But if I take a straight AP view, it's nowhere near his eye. So what's going on here? Here's the lateral view. Oh, this bullet's actually embedded in the back of his calvarium. And it's only because the Waters view is an upward-looking view that it happened to project over his eye, and whereas the AP view shows it's nowhere near his eye. It turns out this patient actually is MR compatible. This bullet's not going to get sucked through his brain, not going to get sucked through his globe. This patient, I don't mind putting in the MR scanner. This patient is not MR compatible. I don't know exactly where this knife blade is, but I certainly don't want it moving from its current location. I think the history here was stabbing chest pain. One final note about metal inside your patients. We talked about safety issues. We talked about no implanted electronics, no metal that can move, but orthopedic hardware is okay, modern aneurysm clips are okay, modern heart valves are okay, vascular stents are okay, filters are okay, all that stuff is fine. But they can cause imaging-related issues. Metal can affect the magnetic field, causing what we call susceptibility artifact. And while this may limit the diagnostic value of the scan, quite often the scans come out just fine. As long as the patient is MR safe, we're willing to try, and I've already told you it's MR safe. If the scan doesn't work and we can't get any images, we cancel the scan, we cancel all charges. I call up the doctor and say, that didn't work, what do you want to try next? But usually we can see just fine. Like take this patient here. This patient has a lot of metal in their body. They've got this rod running the length of their femur. They got some plates fixing their acetabular fracture. Is it unsafe to put this patient in the magnet? No, of course not. My magnet's strong, but it's not that strong. It's not going to suck this rod out of their femur. It's not going to unscrew these screws. This patient had unexplained knee pain. So we put him in the scanner, T1 weighted image, fat is bright, and we are getting a little bit of artifact off the rod, not too bad. But look right there. There's a black line around that femoral condyle. That's a fracture. That's a fracture that even in retrospect, I can't see on the radiographs. I can see beautifully on the MRI. Despite metal there, we do not miss fractures on MRI. Here's one final case. This is somebody who has 2 screws in their knee because they've already fixed their anterior cruciate ligament. The surgeons call these interference screws, but they don't interfere with me. I kind of like them. It shows me exactly where the anterior cruciate ligament should be running. I put him in the MR scanner. Here's a T2 fat suppressed image. We can see fluid is bright, and we are kind of getting a funky psychedelic artifact coming off the screws. But if we look here on the sagittal T2 weighted image, we can actually see that the anterior cruciate ligament graft is intact. Here's that proton density that I said is even better for showing the ligaments. And we can see that the anterior cruciate ligament graft is intact. So that's not the cause of the patient's knee pain. What's the cause of the patient's knee pain? Well, a couple of slices over, here's a line through the posterior horn of their medial meniscus. That's a tear of the posterior horn of the medial meniscus. So despite this patient have 2 screws in their knee, I can tell you unambiguously the ACL graft is intact, the meniscus is torn, metal is usually not a problem if it's not a safety issue. So just to finish up, what to order when, you should always start with radiographs. All of my lectures are going to focus on radiographs. It's certainly the least expensive study, and it may show you the answer. And frankly, I need the radiographs to plan what other studies we're going to do. CT, at least when it comes to musculoskeletal imaging, is used mostly in the emergency department for fracture detections like in the spine. It's used for surgical planning of fractures that we've already detected on radiographs. And it's usually ordered by the treating specialist rather than the primary care provider. Whereas MRI is used for everything: tears, occult fractures, infections, Again, I think MRI is best ordered by the treating specialist. So that's all that I have for you right now. Any questions about anything we've talked about? Okay, thank you.